Okay. Go ahead.
Hello, and welcome to the first lecture in our Geriatric Health Lecture Series. For those of you who have participated in previous series, welcome back, and to others, I think you're going to really get a lot of benefit from this. My name is Barbara Cochran. I'm the director of the Deternier Center in the School of Nursing. Today I'm representing the Northwest Geriatric Education Center, which is the sponsor of this lecture series. And just so you know, I think most of you are aware, we have some 30-odd sites around the region. I would say not just Pacific Northwest, because I think Wyoming's participating, and I'm not sure they'd claim that they would be a Northwest site. And so I hope that you are able to participate in others of these lectures. But today we're really fortunate to have Carin, and now I forgot, Dugowson, sorry, who's going to talk about an incredibly important topic, rheumatology, and one that we don't tend to address a lot in kind of our courses and content and whatnot, so I think there's going to be great interest. Carin is an associate professor of rheumatology. She's also an adjunct associate professor in epidemiology at UW. She's particularly interested in rheumatoid arthritis, osteoporosis, and musculoskeletal problems of women in aging. And I just wanted to also mention, if you could save your questions to the end, you can actually upload them into the chat room, but I probably won't be posing them to Carin until at the end of the lecture. And Carin, welcome.
Thank you.
Sorry I'm so ditzy today.
Oh. So I'm really excited about being here. I've done a number of talks for these kinds of audiences, and I always really like it. Rheumatology is, and always has been, either the first or second most common reason for a visit to a practitioner. And it's been my long-held feeling that that's underappreciated in the training, especially of people who work in outpatient, but also on the inpatient side. So it's a pleasure to give this talk. It's also a pleasure because Michael gave me the choice of topics, so I could do whatever I felt like. And so these are kind of my favorite things for 2013. Rheumatology encompasses everything from the sprain you got when you went skiing or got overexcited shoveling snow to life-threatening diseases that require transplant and chemotherapy. We take kind of all comers for those reasons. At the university, we see more of the serious stuff. And I have to say that for those of you in the outfield, or the boonies, or however you think of yourselves, I am always blown away by the MedCon calls I get about the kind of patients you're managing when you don't have the MRI down the hall, and you can't get a CT of the chest, and you can't get the weird serologies that we're always telling you to get. You guys are really fabulous. And so this is a mixture of the practical and then a little bit of the didactic, which I hope won't make you fall asleep late in the afternoon. So I have these 4 areas. What's new in RA, RA being my all-time favorite disease, especially now that we can treat it. A new medication, a new look at systemic lupus, a new medication for gout, and adult-onset Still's disease. Not because it's so common, but because it's one of those things that when you have a patient, you don't know what to do. Maybe this is what they've got. So let's start with what's new in rheumatoid arthritis. Actually, for a disease that's as common and that we talk about pretty often, there's a whole lot that's been new in RA, and I'm going to try and summarize them now. Just to back up, it is the most common systemic autoimmune disease, unless you count thyroid disease, which I don't. 1% of the population has rheumatoid arthritis. That means not new cases, but anybody in the population who has it now, which is very, very common. The incidence increases through life. So we used to talk about it as a disease of, women in their 30s and 40s, but actually the older you get, the more likely you are to have RA. So if somebody comes in and it's a 72-year-old guy, it could still be rheumatoid arthritis. Until menopause, women are more commonly affected, but after that, it's equally common in both genders. And the other thing is, it's not a benign disease. We used to, years and years ago, look at it and say, well, we'll wait until we see trouble and then we'll treat it. And that is really not true. We have very good information that says you die from RA, not just with it. And that has really led us to the last conclusion, which is therapy should be started early, and early diagnosis is the key. So with that very quick background, let's talk about something that, as an epidemiologist, is really near and dear to my heart, and I'm going to try and convince you that you care too. This is the list of the old new RA criteria, which were, 15 years ago. And for most of you, this is probably what you learned about. And clinically, it makes a lot of sense. These are patients who have morning stiffness. I get out of bed and I feel 100 years old. They have arthritis that's in several areas. Their hands are involved. We talk a lot about symmetric arthritis. And then they have a nodule or rheumatoid factor or erosions. Those are the classic RA, and it's what many of us grew up on. But now the really new classification of RA looks totally different, and it's not intuitive about why they did that. So let's just look at it. You want to add the score of 4 different categories, and if you have 6 out of 10 points, then you have RA. And actually, it's not really called definite RA, it's just called RA these days. So you get different scores for different amounts of and patterns of joints, but if you have more than 4 small joints, which are the little joints, your MCPs, your PIPs, not your shoulders or elbows, you automatically get 3 points. And if you have more than 10, you get 5 points. You're close to having the diagnosis. And if somebody comes to you and they have really swollen joints in their hands, you're just about there. The next thing is serology. A negative rheumatoid factor, negative anti-citrulline antibody, you don't get anything. If you have a little bit of one or the other, you get 1. But if you get 2. But if you have a high positive one, you get 3. If you have a SED rate or a CRP that's elevated, you get 1. And if it's been there for more than 6 weeks, you get 1. So it's pretty easy, if you look at it, for somebody who's got a high SED rate and 6 weeks of symptoms and a few joints to be told they have RA. So what's different about this? Well, there are a couple of things. First of all, they got rid of a lot of the criteria that we used to think of were key to the diagnosis. Morning stiffness, symmetry, nodules, and x-rays. What have they added? Well, they've added the acute phase reactants as a measure of inflammation. They've added the anti-CCP, and that the higher the titer, the more significant it is. Why did they do this to me right after I learned the old new criteria? Well, the basic reason is that we have been striving to identify early rheumatoid arthritis so we can get in there and treat it. And it's a huge philosophical change about the therapy of RA, especially in the larger population, not just the small group of young women who present with classic RA. The older patient who presents with larger joint and multiple joints, where it might almost look like polymyalgia rheumatica, all of these patients are better captured with some of these criteria. So they added the ones that you can see early on as well, and I'll show you about the CCP. They took away morning stiffness because it doesn't say enough about whether it's lupus or any other thing, or just really old age, where you say it takes me a long time to get going. So it's not a good discriminator. So they wanted to find rheumatoid arthritis that was likely to persist and have a poor clinical outcome, and that's why the criteria look so different. Why do we want to do this? Well, there are really 2 reasons. One is early treatment for clinical patients and also clinical trials. So when you start to read, if you read the trials of the new drugs, you're going to see these more and more. So some of these patients are not going to go on to have persistent disease. They're going to have a variant of a viral syndrome, and they're going to have had a lot of synovitis, but most of them are going to have RA. And from an epidemiologist description, we sacrifice specificity, meaning we're going to include some people who don't have it for sensitivity, meaning we're trying to get anybody who is at really serious risk for having persistent rheumatoid arthritis. And that's because we have better ways of treating it. One of the reasons we have better ways of treating it is we have this new lab test, which is called the semi-new, you've probably heard of it already, called the anti-CCP. So anti-CCP are autoantibodies, that is, antibodies that we make against our own proteins. And in the literature, you'll see this other unwieldy title called ACPA-ACPAs, which is anti-citrullinated peptide antibodies, and it's because of citrulline is the particular compound. We don't call them that in the clinic, and they don't say that on the lab sheet, but they are the same. So anti-CCP is what we call them. 50 to 70% of RA patients have them, so it doesn't tell you all of the RA patients. Only 2% of the general population has it, and it's not generally seen in other immune diseases. So it's really a kind of nice discriminator because it portends a worse prognosis. So if you start out from the get-go with a high anti-CCP, I'm going to pay attention to this right away. The other thing that I think is really interesting, not necessarily good, is that smoking and gingival disease can induce the citrullination of proteins. So periodontal disease and tobacco are two of the few things that we can actually, as specialists or as primary care providers, intervene with and say, if you stop doing this, your risk of either getting the disease or more likely the severity is likely to go down. So I'm going to show you some pictures now of the time course of these antibodies and why I think they're particularly fascinating. If you look at the bottom line, it says 15 down to 0, and that's years before the onset of symptoms. So 0 is when they're actually diagnosed with RA. If you look at the purple, which is the anti-CCP, you can start seeing these autoantibodies 14 years before they have clinical onset of disease. This is far in advance of the IgM rheumatoid factor. And they start to get pretty high 3 or 4 years beforehand. Now, we don't screen everybody to see if they're going to have RA, but if someone is in a high-risk family or if they've had unusual symptoms, you may want to have them on your watch list. And this is very specific, again, as I said, for rheumatoid arthritis. So let's put that into the mix with this new risk factor of smoking. There is, in addition to rheumatoid arthritis, a genetic susceptibility, and that's what it means at the very top right of that thing. It's the HLA, sometimes called DR4, DRB1. It's a shared epitope. So it's an inherited characteristic that you've got it or you don't have it. It's not changeable. You can get one dose from either parent, so it's 0, 1, or 2. If you look at this little structure, these are for people who do not have anti-CCP in their blood and they don't smoke. And you can see that the relative risk doesn't change. So hold that thought and then look here. This is the interactive risk between people who have smoking, anti-CCP, and the shared epitope. Smoking, which is the far right back one, has a relative risk of 25 compared to any of the other combinations. So if you inherit the shared epitope and you smoke and you have this autoantibody, you are in big trouble. I don't know who said that. That was God. Hello. So again, you can do a lot to mitigate your patient's risk for trouble by getting them to stop smoking. And I'm always happy to see that there are things that I can do that don't involve medication and that can mitigate risk of disease. So I'm going to go quickly on to a couple of new therapies. Abatacept is also called Orencia. It's been used as an intravenous infusion for several years. It's a monthly infusion. We like it a lot clinically. It's pretty easy. There are not a lot of infusion reactions. And I'm happy to tell you that it's now available in an injectable form. So patients who would otherwise be good candidates but can't get close to an infusion center can come and get these. It's easy to do, and for people who are not very mobile, for example, somebody who's in a nursing home or is otherwise debilitated, this is a very nice drug. Tofacitinib, which I've been practicing saying, just got approved about 6 weeks ago. I think Xeljanz is a kind of weird name, but I don't know, maybe it's easier than the other one. And it is a unique new mechanism. I'm not going to go into most of the details for a couple of reasons. One is nobody in our clinic has used it yet, and we're not going to use it until some other places get some clinical experience and have the unexpected adverse events first, and then we can decide if we like it or not. But it is interesting because it's an oral small molecule, which has not been something that's been typical for rheumatoid arthritis or any of the immune modulators. These are almost always proteins that you can't eat because you digest them. So this is really a new wave of therapies, and it's why I was saying that pharmacy is really on the cutting edge, and we're very grateful. It has kind of typical issues around lipid changes, LFT changes, but since we've not used it, I can't say anything about it other than it's great to have another drug. One that's not so new but hasn't been used is tocilizumab, which is Actemra. That is a more typical intravenous infusion. It inhibits IL-6, which is the most direct cytokine inhibition, and it drops your CRP like a rock. I did the clinical trials with it and was hugely impressed, both in new RA and refractory RA. I'm not so sure. I've become more fond of abatacept, and now that it's injectable. So those are the 3 new things. There are going to be more. They're going to have weird names, and just the way that Enbrel and Humira used to be weird to us, they will assume their place in our armamentarium. And the way they will assume their place is that we're going to now treat to remission. It used to be that we would treat people to make them feel better or to try to make their scores go down in terms of number of swollen joints, but we didn't really say we want to make every bit of synovitis go away and every bit of clinical symptomatology disappear. And that approach is partly because we've stolen all of the chemotherapy drugs from cancer where they always aim for remission, but also we have good data now that if you do that, people have less disease in terms of damage and they have a better quality of life. And that evidence is quite robust, and it's worth pushing on how you're going to do it. It's also helped by the fact that we have so many more medications now, so there are 5 or 6 different anti-TNF agents, and if you don't do well with one, you can try a second if you need to go to an injectable if they have liver trouble. So we have a lot more possibility, and the goal is to say, I want you to wake up in the morning and you're not even going to think about the fact that you have RA. And that's a very, very different attitude, and it will probably color the conversations that we have in MedCon about what to do and what to do next. So it's a wonderful day, I think, in terms of rheumatoid arthritis management, that we have the data that says we should do it and the drugs that say we should manage it, and that we're going forward with that. So when we're talking about questions, I'm happy to take more specific clinical questions about how to do it and the drugs, rather than spend time here doing that. So this is the bottom line. It's not a unitary disease, because you can have erosions, you cannot have erosions, you can have lung disease, you can have nodules. New criteria focus on the early treatable disease, hopefully before these things have developed. The therapies are increasingly directed to very specific targets, cytokines, specific kinds of cell subsets, so that we hope that we will knock off the troublemaker and leave the rest of the immune system intact. We're thinking more and more about environmental modification of disease risks. Smoking is about the best example that I can come up with. And as I said, early therapy and treatment to remission are the standard of care. So that is rheumatoid arthritis. Now you know everything. You can go out and treat it. So let's take the next talk, lupus. This is how I think about lupus, the blind men and the lupus elephant. Lupus is a really hard disease to treat. It's hard for rheumatologists, it's hard for primary care doctors, and it's hard for primary care doctors out in the outfield who don't have access to necessarily all of the tests. These are the most common pieces of lupus. The arthritis is one that we commonly see. Serositis, the chest pain, the pericarditis, CNS disease, not just thrombocytopenia, but all of the cytopenias. You can have a low white count, you can have anemia, you can have hemolysis of the cells, and as well as low platelets. You can have nephritis or renal disease, you can have abnormal clotting, and really the body of the elephant is the fatigue and the overwhelming sense of unhealthiness that the lupus patient has. I didn't even put on the issues around pregnancy, which are not geriatric issues, I hope. So it used to be that lupus was felt to be a disease of young women of color. It's not very common. It's about a tenth as common as rheumatoid arthritis. But the incidence has tripled in the last 40 years. I used to think that it was due to the fact that we had better lab tests, that our ANA testing was more sensitive. But I've recently seen literature that does not suggest that and suggests otherwise, that the disease is just getting more common. And that's somewhat disconcerting. We have identified urban dwellers adjusted for ethnicity and where they were born and a host of other things as being more of a risk than rural risk. So that obviously opens a whole lot of speculation about what are the environmental issues that would lead us to have more lupus now than we did a while ago, and that's certainly concerning. It's more common in African Americans than Hispanics and Asians, and Caucasians are the least common. Native Americans and Pacific Islanders are not as well counted because they're smaller populations, but it's my sense from the numbers I've seen that they're somewhere between Hispanic and African Americans. So both in terms of risk and in terms of adverse outcomes, I think that often the outcome for these patients is unfortunately not very good. But amazingly enough, if you go to examine Africans in Africa, it's a very rare disease. So that is a huge unexplained discrepancy. It's not, I just can't make sense of it. If you were going to say, well, it's because African Americans they're not just African American, but they're heterogeneous and there's Caucasian blood, well then why don't Caucasians have more disease? It's not that the diet is that different. I just don't know. It's not been studied enough. I think it's really important, and one of the reasons it's really important is we know now that the medicines that we use don't work the same in different ethnic groups. The very first time I saw it was with one of the earlier antihypertensives, where it was demonstrated that it was better in African Americans than Caucasians. Here, we have evidence in one of the more commonly used drugs, mycophenolate, that it doesn't work as well. These are just very important studies to be done to make sure that we can customize the therapy. I think it's going to be the advent of, genetic customization for patients that I look forward to. But it's a very troubling thing right now to not know what the best regimen is based on patient characteristics. In the old days, 90% of patients were female. The latest registry I saw was about 85%. So it's still much more a disease of women. The age of onset is still relatively young. But there's not a law that says a 62-year-old man can't have systemic lupus. And you have to think about it, because if you don't think about it, you won't see it. And we see it every month or so. We see somebody who just doesn't fit the classic demographics. So in 2013, there are a number of things that have, I think, been better for lupus. The first is that mycophenolate, or MMF is how you'll commonly see it written, has been shown to be effective for nephritis. In most studies, it's shown to be as effective for maintenance of remission after cyclophosphamide for renal disease and for induction of remission. This is one of the places where we're not sure about African Americans, but it's a very easy drug compared to cyclophosphamide. It's oral. You can manage it in terms of the cytopenias. It doesn't have the long-term consequences. This is not a geriatric issue again, but cyclophosphamide given to young women is very hard on fertility, and the older woman over 30, over 35, can easily become infertile with cyclophosphamide therapy. So this is an alternative that we hope is going to turn out. Other drugs that are being tested are abatacept. It works in a totally different way than the other drugs, and it also works in a different way than anti-TNF. Just parenthetically, drugs that work for rheumatoid arthritis can exacerbate or cause lupus and vice versa. So there are not very many drugs other than steroids where you can say, gee, I don't know what they've got. I can give them either one. If abatacept proved to be one of those, it would be very wonderful. Raynaud's is almost always present in lupus, and probably in the colder climes you see more Raynaud's than we do even here. Sildenafil is a nice adjunct to the calcium channel blockers, and when you have people with not very much blood pressure that you don't want to vasodilate them anymore, this can be very helpful. One of the things I think is really important when you're the manager of somebody with lupus is looking at the issues that are not the disease directly. So that means infection risk. You absolutely need to have them immunized, and it needs to be done on a regular basis. And you need to look at their lipids, their blood pressure, and their risk for ASCVD. When people have adverse events from lupus, it's often that they have it with lupus. It's that other category of infections and MIs, early strokes. For women in their 40s and 50s who have lupus, it's a very serious problem. The onset of heart disease is one of the earliest signs of end organ damage. So I would urge you to be quite aggressive about lipid management and blood pressure management. There's also been early reports about unusual cancers that have been seen both with lupus and with lupus on therapy. I don't think that those two issues have been fully separated. Azathioprine, which is commonly used, is certainly one of the potentials, but carcinoma in situ of early CIN is a big problem, and so I have my women routinely under surveillance in GYN and just say, please pay attention to this. Unfortunately, I'm finding much more of it than I was thinking I would. There's no news on 3 of the areas that are common causes for lupus patients to be sent to us for consultation. Neuropsychiatric, pregnancy, and antiphospholipid syndrome, there's really not been any change. We're still doing the best we can. But there is a new drug. It's called belimumab. Benlysta is the brand name. And there are a lot of good things about this. Although it's new and I don't have really a solid take-home, our overall impression in the clinic and my personal experience is that it's a pretty good drug. First of all, it's fully human, which means that you're not going to make antibodies to the medicine. That's a problem that we see with Remicade, for example, that you can use it for RA and it's great, but over time it becomes less effective. So the newer drugs are all fully human. It blocks a compound that we call bliss, which seems sort of strange because it's not very blissful, but it was discovered by a pharmaceutical company searching the gene databases. So it is a true designer drug. They identified it as something that had a very bright signature in the scans of patients with lupus. They said, gee, I don't know what this is, but maybe it's a target. Then they went back and looked at what it did, and then they made a drug against it. I think it's incredibly cool. So it's been on the market for over a year. It's a monthly IV infusion. You give it along with methotrexate or azathioprine, kind of the same as with the other stuff. You cannot use it with other biologics because it's too immunosuppressive. It is the first new drug that has been approved for lupus in 50 years. A couple of years ago, when I was talking about lupus, I would say, oh, and rituximab is in trials and it's going to be approved. And Rituxan failed all of its studies. It failed to make the lupus, and it failed to make the lupus nephritis endpoint, so it's not been approved. However, Benlysta has been approved for mild disease. So you cannot get it for nephritis or CNS disease. I've actually had trouble getting it for somebody who used to have nephritis, but for mild lupus, which is arthritis or pleurisy or Raynaud's, which you probably wouldn't do, it's been very easy to get. The other thing is I've had a number of patients in the clinic who have low platelets or low white count. This seems to have worked just like a charm. It's just been a pleasure. Knock on wood. I'm hoping it all goes well. We haven't had troubles with a lot of infections or other adverse effects, and there aren't good data yet in African Americans because the numbers from those few Benlysta studies were too small. But the post-approval surveillance will help us know, and I'm sure in a year we'll see little studies about how it works in different demographics, which is really nice. Okay, that's all I'm going to say about lupus. This is a dragon sculpture in Borrego Springs, which I think is cool. And I thought it was fitting because we're going to talk about gout, which is kind of like, oh, my joint's on fire. Gout is probably something that you treat far more commonly than either lupus or rheumatoid arthritis. And unfortunately, because our population is still obese, hypertensive, and not eating the right foods, it's kind of a boom business. Unfortunately, one of the biggest drugs that we like to use, which is colchicine, has been kind of priced out of the market for a lot of people in the last couple of years. And we've got a lot of calls about what the heck is going on. So here's the little story on colchicine. Colchicine was an orphan drug, meaning that it had been grandfathered in by the FDA as safe. And in the effort of getting evidence-based information, the FDA said if a company was willing to do a double-blind, randomized controlled study of colchicine in gout, they could get complete sole rights for either 3 or 5 years. So this company did a little study, and it was really easy because colchicine works so very well. They didn't need all that many people, and they demonstrated in a perfectly well-done study that gout was effective. So the price went from a dime to $5 a pill. And they have sole control over it, and that started in 2011. So we're hoping that sometime at the end of this year, the exclusivity for acute gout will be over. In the meantime, unfortunately, there is not really a great substitute. The company does some support of copays, but we've really had a lot of misery with patients who have been on colchicine for really long periods of time. One trick that we have found is for the small number of patients who are also on probenecid, colbenamide is a drug that's been pretty cheap and some patients have been able to get. But for people who just take colchicine, it's really, I don't know, it's like no good deed goes unpunished. It's really wrong. Anyway, that's the story of that. On the other hand, there have been a couple of new therapies for gout that actually are quite new, and I don't think that you're going to use them commonly in your clinic, but for the patient who has recurrent, refractory, I don't know what to do with gout, this is a very promising avenue. So pegylation means that it's a protein that's added on to a chemical or a medicine, and it increases the lifespan in the bloodstream. That's what pegylation in general does. And that's good for drugs that you don't want to have excreted so quickly because you want them to hang around and work whatever they're supposed to do. So this pegloticase is a urate oxidase enzyme, which we commonly call uricase, which converts uric acid to an inactive water-soluble form, allantoin. And this is the stuff that makes bird poop white. So evolutionarily, birds all have uricase, and they never get gout because they don't ever accumulate high levels of uric acid. One can only wonder why humans lost the uricase. It's a big mistake. So we have been trying to replace that artificially. And it's not that easy because, again, it's a drug that the body tends to be very sensitive to, this more than others. And they've not been able to find something that you can give at an infrequent enough dose with few enough side effects and adequate efficacy to make it worthwhile. So pegloticase is only for really refractory gout, and you need to really reserve it for rapid remediation. So what does that mean? Well, say somebody has they come to you, they've had gout for 25 years, but now they decide to come see you, and they have tophi on their elbows, and they're all breaking down and infected. And you kind of go to yourself, where were they for the last 10 years? But then you say, well, maybe I should use pegloticase, because that's one of the fastest ways to get rid of tophi. If you put somebody on allopurinol and they have horrible tophaceous disease, or even worse, if you put them on probenecid, you are going to be very old before their tophi are gone. And that patient, it's just the wrong timeline. So that's kind of where we think about using pegloticase. It really doesn't happen very often. And part of the reason is that the risk of hypersensitivity reactions is pretty high. You have to do it intravenously every 2 weeks, and it's just not easy. On the other hand, every now and then it's the only thing to do. And like I say, recurrently infected tophi is probably the most important. We have several Pacific Islander families that have just horrible gout. They clearly have some genetic predisposition, and 28-year-olds are coming in with big tophi. So those are the people for whom we would consider doing something like that. Okay, heading for the finish. Adult-onset Still's disease. So this is it's not very common, you may not see it, and why is it interesting? Well, there are a lot of autoimmune illnesses where fever is a common thread. RA and lupus are not particularly one of them, although you can see fever. And when someone is febrile, it's often very challenging to sort out what it is that's causing the fever. So when you think about persistent fever, we think infection, malignancy, autoimmune disease. Well, when you've ruled out the other two and you still don't know what it is, you can think about adult-onset Still's disease. This is one of the most common. You look at people who have joint pains, recurrent or persistent fever, who do not meet criteria and are not infected. The first thing that's characteristic of this is what's called the salmon-colored rash. And it's really kind of an evanescent pink thing that generally disappears when the intern is in the room and appears when the attending is there. It's very convenient. So, but it's not a persistent, it's not going to always be there. It's not like a drug eruption. The other thing that's characteristic about them is that the ferritin is very high. So greater than 3,000, greater than 10,000. We've seen 15,000 as a ferritin. Presumably as an acute phase reactant, we can't figure out a pathophysiology that says it's not an iron overload disease, but ferritin is one of the characteristics. Dr. Yamaguchi came up with these criteria, and they are actually helpful. So you have to have a big fever, 39 degrees, persistently for a week. Persistent arthralgias or arthritis, the salmon-colored evanescent rash that comes particularly during the febrile episodes, but not only, and then an elevated white count. And other things that you see or sore throat, lymphadenopathy. I've seen a lot of splenomegaly and hepatomegaly. These people get repeatedly tested because you think they have mono. They look kind of like a mono patient. So in somebody who is older than your typical mono patient, this is something to think about if the mono spot is negative after you've done it 3 times. You see elevated AST and ALT, and they have negative ANA and rheumatoid factors. So part of it's exclusion, which is good because they're staying there febrile for a whole week and you're doing all these things, and now you have something else that you can do. Why do we care? Because we have a great treatment for it. Anakinra, which the brand name is Kineret, is a drug that was approved for rheumatoid arthritis quite a while ago, right around when Enbrel came out. It's a recombinant IL-1 receptor antagonist. So IL-1 is one of the major cytokines that causes fever. So this is a direct target on getting rid of the fever. And it's very effective. You give it as a sub-Q injection. It's 100 milligrams per day for most people. And these people who have fever curves that are up like this, they plummet. It is very gratifying. And it's pretty specific for adult-onset Still's disease. And if they don't respond, that means they probably don't have it. The other reason I like to mention it is we use it here for refractory gout. We use it in hospitalized patients, people who have had bone marrow transplants and they have no white cells and we can't put needles in anywhere, and they have 5 joints that are involved, so we're not going to do that, and the transplant team won't let us do steroids, and we can't give them NSAIDs because their creatinine's too, and the pharmacist is going, well, so we bring out the anakinra, and it's very, very nice. You do it for 3 days, usually breaks the cycle, and then you can go on to whatever you're going to do. There are other IL-1 inhibitors. Canakinumab was also recently approved. And this other phrase at the bottom, cryopyrin-associated periodic syndromes, or CAPS, it's just another febrile disease syndrome, which we don't diagnose very much. It's more in the pediatric literature. But if you see it, that's where it comes from. And I think that IL-1 blockade is a useful thing to think about in these febrile illnesses. I think what's interesting, when you give it for gout, it's kind of, if the tree falls in the forest and there's no one to hear it, the gout crystal's still there. The white cells are still there. But the IL-1 is blocking the ability of them to be creating a fever. They're not phlogistic anymore, the way they used to talk about it. So it's a fascinating, again, direct approach that doesn't cure the hyperuricemia, and it doesn't tell you that they're not going to have destruction of their joints from hyperuricemia, but it gets you out of that acute situation where you have to make them able to get out of bed, go to the bathroom, and not be in acute pain. So that's the end of my 4 topics. I've tried to leave a whole lot of time for questions. Do you want me to go over the questions that I put for the end of the lecture? You guys all have the answers. So I'm happy to take questions on any of that, anything else that I didn't talk about, which is most of rheumatology.
So if you want to just say something like, John, please open up the chat.
Okay, John, could you open up the chat box? Maybe, maybe not. Come on, don't be shy. You call me all the time on MedCon. I'm that same person. It's okay.
Are all, oh,
We have technical difficulties.
No.
Please excuse
We
us.
just have a couple buttons we have to push. So here's your questions here.
and
Francis House book, are these new drugs
Okay.
very expensive? And then another one's writing down here.
Okay, so the question is, are these new drugs very expensive? Yes. That's the short answer. The longer answer is that almost all of the pharmaceutical companies now have programs for people who cannot pay or whose copays are very high. And if you are interested in using one of those medicines, it's very wise to get a hold of the drug rep for that company. The biggest frustration we've had is that copay support is never given to people with Medicare. And it's some rule that I don't understand and drives me nuts. So that's not a group you can get it to, but you can get support a lot of the time.
And how are the Part D formularies in terms of covering these medications?
If you meet the indication, they're very good. So, for example, the Benlysta, belimumab issue, the patient I thought was eligible because she no longer had nephritis, but they wouldn't fund it. And then, so we're in the process of arguing that, which eventually I'll win, but that's how they kind of do it because they are expensive drugs. And every month they don't give it to the patient, they save money. Okay. With adult-onset Still's disease, will joints be swollen? Yes, they will. It's an arthritis that looks very much like RA, except they have negative rheumatoid factors. I don't actually know the cost for the anti-CCP. I'm really sorry. I'll find that out from Mark Wenner, the lab director, and get it out to you. Those are all the questions that I have.
One more coming in.
We have one in the room here.
So, is there treatment difference for older adults and younger adults in terms of?
Yes. The question is, are there differences in treatment between younger and older adults? And the answer in general is yes, because of associated comorbidities. So when we go to give a drug, like prednisone, for example, which is one of the most common ones we use, you have to pay attention to the side effects, which are hypertension, hyperglycemia, long-term induction of cataracts, long-term bone damage. These are all far more prevalent in older people than young people. So you assess each person individually for those risks, but you know that they're more commonly problematic in the older patient. Other side effects are just disproportionately present in the geriatric. For example, I have never had steroid-induced psychosis in anyone who is younger than 65. And that comes up in the treatment of polymyalgia rheumatica or giant cell arteritis, which is a disease where you absolutely have to use high doses of steroids because the risk of blindness is so severe. But I have, over the years, unfortunately, had 2 people who ended up in locked psych wards because the steroids made them crazy. So prednisone is one of the most common ones. Other ones, it's really more you look at what their renal function is and what their blood pressure is, what their breathing is, and it's individually how you assess them. I think that the risk for older people is polypharmacy in general, and so it's really important to try to have very accurate med lists because often they're seeing so many different doctors and the doctors are putzing around and you don't know if the list that they bring you is the actual up-to-date one. So it's a really good question, and you know, the electronic medical record is supposed to fix that someday, but has not yet.
What about alternative treatments for RA or lupus?
I think the most common alternative, which I don't think is really an alternative, would be dietary management. There are good data showing that vegetarians and vegans tend to have less inflammatory joint disease. They have their own problems, which is iron deficiency and so on. But if you want to make your diet somewhat less inflammatory, you would add things that are high in flaxseed, omega-3 unsaturated fats, and such like that. I don't think that there's really proof about some of the other supplements. Many patients take CoQ10 and SAMe, and those data are lacking. The other thing in diet that people are commonly interested in is what about elimination diets or foods that are particularly a problem. And the ones that I hear most about are the nightshade or tomatoes and potatoes. Again, there are no data that says that's true. If I have someone who wants to investigate dietary modification, what I ask them to do is change their diet for a minimum of 6 to 8 weeks and try not to change things, multiple things in waves, so that we can say, yeah, you took the dairy out and it helped, or you took the dairy out and it didn't help. Sometimes people go on rather stringent diets and then we add things back, and that's fine with me too. But really it's trying to control the variables. The last interesting group are people who take gluten out of their diet. Gluten disease and gluten sensitivity are not exactly the same thing. So gluten disease is one where if I measure the antibodies, they're going to be positive, and if we were to biopsy their small intestine, it would be abnormal. People who are sensitive to gluten will have negative autoantibodies, but they can still report significant improvement in how they feel. So it's really easy to eat a gluten-free diet today compared to 10 years ago. And so I'm fine if people want to do that and, you know, see how it turns out. Did you have another one?
Does trauma or injury potentially speed up the illness?
It depends on what you've done. I think generally speaking, no. If you have damaged the joint that's also inflamed, yes, it would, but I think in all it generally doesn't. Someone says, how long can remission last if you have been treated for rheumatoid arthritis? RA can go away. It doesn't happen all that often, but I think that now that we are treating more aggressively and earlier, I think that we have a much better chance of doing that. There are some researchers who think there is a window of opportunity that's within the first to third year of rheumatoid arthritis, and if you just beat it senseless, that you can stay in remission. I am one of the people who thinks that that aggressive approach is the way to go. So the other thing is when it goes away and it stays away, then you say, well, did they just have a viral infection and, you know, you got a reactive arthritis. But if it's gone, everybody's happy. If you have damage, if you have erosions, it's less likely to happen. But after 10 or 12 years, there are quite a few people who have what we call burned out RA. They typically will have some damage, secondary osteoarthritis, but the inflammation goes away and then you stop the medicines, the immunomodulatory medicines. So, how long can you stay on the same drug for RA? Do the meds lose their effectiveness? So I have people who have been on hydroxychloroquine for over 20 years. I have Enbrel patients who've been on it since it came out in 1998. So you can stay on it if it continues to work. Generally, you won't get delayed adverse effects. On the other hand, there is a significant percentage in RA with the anti-TNF agents where they tachyphylax and it becomes less effective over time. So the data show that if you have somebody on Enbrel and it loses its effectiveness, you can go to Humira or Remicade, which is not exactly the same anti-TNF mechanism. You have an 80% chance of their going into some sort of remission or improving to the same extent with that second TNF. By the time you get to the third one, the likelihood is much lower. So I personally will always do a second, less commonly do a third unless the patient doesn't have any other insurance options. And in terms of staying on other things like azathioprine or methotrexate, those are really long-term medications. They don't acquire immunogenicity and they tend to do what you want them to do for a long time.
Is anyone investigating secondhand smoke exposure as a risk factor for development of RA?
That is a great question. I think that the answer almost for sure has to be yes. We know that smoking is a problem. If you're inhaling it, whether you put it out there or someone else did, I would think, I don't know, it's a good thing. You could ask the School of Environmental Health or, I don't know, it's a great grad student project.
Briefly go over the objective measures that accompany lupus.
Oh, yeah. Well, let me think about I have to come up with the 7 or 8 ones that are currently used. They just revised them. Cytopenias, neurologic abnormalities, arthritis, not arthralgias, a positive ANA, photosensitive rash, abnormal urine, and one more I can't remember off the top of my head. So I got you 6 of 7. I'll send you those too, I promise. Does glucosamine have any impact on RA? Glucosamine has been studied in 2 different forms. One is the glucosamine sulfate, and one is the glucosamine hydrochloride. The sulfate is what's made by a pharmaceutical company, and it's a prescription drug. The hydrochloride doesn't seem to have any really beneficial effect on anything. Repeat studies on OA, to my dismay, don't seem to have panned out. The sulfate, glucosamine sulfate, has been touted for a long time. One of my colleagues, Peter Simkin, wonders whether it's the sulfate and not the glucosamine, because that's really important in collagen structure. But the general answer, sadly, is no. I have patients who swear by it. It doesn't do anything bad. So it's not one of the things I choose to fight about. Are there more questions here? Let's see. Did I answer the alternative questions for lupus? I think so. They're basically... Oh, actually, in lupus, there are a couple of others that people do. DHEA has been very popular over the years. And I actually think that the small studies suggest that it can be helpful. If you had somebody who had very mild lupus and was really opposed to any conventional medicine, DHEA might be something that you could try.
What's the thought about the mechanism for that?
Well, lupus has a long relationship with hormones, especially estrogen. And so the notion is that somehow it's modifying the estrogen profile in a way to decrease the inflammatory nature of the beast. I don't think anybody has gotten beyond that. You know, RA, when you get pregnant, you go into remission 80% of the time. In lupus, it's not predictable at all. It doesn't seem to help. And lupus is much more associated with pregnancy failure and miscarriages along the way, as well as abnormal clotting, which is also related to estrogen. So there's kind of this backdoor confounding of lupus, hormones, clotting, pregnancy.
So there's a question, I think, that's asking to sort of go over, again, the distinctions between osteoarthritis and RA.
Oh, sure. Okay. So someone comes in and a joint hurts, and the first thing that goes into my mind is this inflammatory or mechanical? Inflammatory means autoimmune. So what does an autoimmune joint look like? Well, they tend to be red, they tend to be hot, they tend to be stiff in the morning. A mechanical joint can be swollen, especially if you've been running on a bad knee, but it's not red and it's not hot. I should say that gout is not exactly autoimmune, but it is inflammatory. So you get the red hot joint there, and you get the red hot joint in an infected joint. But so if you have a joint that is swollen, red and hot, it is probably not just mechanical. Mechanical, regional, wear and tear, those are all words for osteoarthritis, meaning that the joint has been damaged by somehow a repetitive motion of the cartilage, which is no longer smooth, rubbing against itself. Or there's an anatomic derangement, like your knee is loose because you tore a ligament and it's moving around and rubbing itself. Or you were a baseball pitcher and you pitched a bazillion pitches and you wore your rotator cuff out and now your humeral head is rubbing. So that's the general mechanism of osteoarthritis wherever it is. The joints are somewhat different. So OA joints are neck, the base of your thumb, because that's where you do all the pinch and grasp, your hips and knees because they're weight-bearing. Interestingly, your ankles are not commonly affected in osteoarthritis. And the inflammatory joints are the small joints of the hands and feet, and then coming in proximally. And nobody has ever successfully explained why that is. So I hope does that answer the question?
I think so. They asked about the relationship, but I'm not sure.
Let's see. The relationship is if you have RA and the joint quiets down, you still have probably damaged the cartilage and you'll have osteoarthritis after it. If you have OA, it doesn't predispose to rheumatoid arthritis. And I don't know what Adequan is. Someone's asking, Adequan has been used in horses. Do I know of any uses in humans? So you have to tell me what Adequan is.
They're typing.
I can tell. Maybe we should try it. They used to use butazolidine in horses and humans, and they don't use it in humans anymore, so hard to know. Nope.
Stop typing.
Typing again. Drug used for joints in horses. Well, we could try looking it up. I can look it up on my smartphone and see. Adequan. It's a race who finds it first. Go.
It's used in dogs, too.
Oh boy. Oh yeah, see it's listed under horse arthritis.
An injectable polysulfatic glycosaminoglycan.
Oh, it's probably a glucosamine cousin. Or, you know, the other thing is, I know what it is. It's like Hyalgan or the injectable OA drugs like Synvisc. That's what it's like. And yes, it is used in humans for osteoarthritis, not for RA. So that's just a synthetic lubricant that people use. No one really understands why it works because it's out of the joint supposedly within a few hours, but you can get persistent relief. You do one injection a week for 3 weeks or 5 weeks, depending on the preparation. I think that's what, yeah, I think that's what it is.
So Anchorage is asking, how is RA, lupus, and gout generally related to each other?
Gout is not related to lupus or RA. Gout is a crystal disease that's caused by too much uric acid floating around in the blood that goes to a place that's generally cooler, like a big toe or a hand, and it goes from being a supersaturated solution to going into the joint. And it's a small needle-shaped crystal that generates a lot of white cell activity and causes inflammation sometimes. What's interesting is, you know, people will have uric acid crystals in their joints for a long time and not always have gout. And we don't know if it's that they get one extra crystal that topples it over, or they get cold, or they get hot, or it gets banged. These little crystals tend to like to hang out in shaggy areas of cartilage, so places like your big toe that usually have a little arthritis, or down in your thumb. So that's gout. It's entirely a really chemical, not an immune or an autoimmune response. If your uric acid is not high, it's extremely unlikely that you'll ever have gout. Rheumatoid arthritis and lupus are both autoimmune diseases, meaning that something in your body is triggering an inappropriate response by your immune system. We know that in lupus there are abnormalities pre-existent in the immune system that make you susceptible to this disease, and whether it takes some other exposure is unclear, but it's mostly, I think, a predisposition. Rheumatoid arthritis is probably similar. There's a lot of information about triggers for RA as well. And although they both land in the joints, they are very different diseases. So RA is kind of a joint problem by and large. You may feel crummy, but it doesn't affect your kidneys, it doesn't affect your blood, and it can affect your lungs, but mostly it affects your joints, whereas lupus is typically involving other places, your chest lining, the lungs itself, your blood count, your kidneys, your nervous system. So it's a total part of your body involvement. And although they both can look the same with swollen hands, that's about the only thing that they have in common pathophysiologically. Prednisone works for both of them, and then there are a couple of other drugs that work for both, but mostly things that work for one don't work for the other.
Can you review diet recommendations in gout?
Yeah. So the most interesting diet recommendation is to take high fructose corn syrup out of your diet. There are very compelling studies that show that this is a very high risk for gout. Other things that are talked about a lot are shellfish and organ meats. And I think those are correct, but I think when you look at the diet of people who have recurrent gout, you find that they have very commonly a lot of high fructose corn syrup in their diet. Gout is also highly associated with the metabolic syndrome, as you probably know, and so there are other good reasons to get that out. But that's the primary thing that I talk to patients about, in addition to diet being, please get your weight down, which I'm sure I'm just as successful as everyone else. But if you start reading labels, high fructose corn syrup is truly epidemic, and it's in bread, so it's in a lot of different places. So I think that would be the key new recommendation, and the rest of them, shellfish and organ meats. I personally think it's uncommon around here for that to be a problem. I think maybe there are other populations where the diet is very heavy on shellfish or other things, but I don't know that.
Given the new criteria for RA, how would one distinguish it from other arthritis like psoriatic arthritis?
That's a really good question. And I think that's kind of the issue. If they clearly have psoriasis and they do not have X-ray changes, then it gets harder and harder. So you can have a rheumatoid factor positive in psoriatic arthritis, but it's not as common. You shouldn't have a psoriatic rash, and the erosions in RA and psoriasis are different. So those are the ways that you can do it. If a lot of the medications that are successful in treating RA are also successful in psoriatic arthritis. So if you're not in a clinical trial, it may be less important. Then you get to the philosophical question of, is arthritis with psoriasis and a negative rheumatoid factor psoriatic arthritis or seronegative RA? And I think at some point you just can only say that it's an inflammatory arthritis, and luckily methotrexate and Enbrel or some other TNF work equally well in both those cases. And sometimes you just have to use time as a variable.
So I'll ask a question in the meantime. Are there any particular regional differences in disease prevalence for any of these?
Not really. Not like MS is common in the Northwest. No. Well, I think the only association is that historically African Americans are much more likely to have lived in the South, and so lupus used to be a lot more common down there, but with great migration of people, it's really more ethnicity rather than location.
I'm not sure if he's typing or if he's abandoned his message halfway through.
Okay. Someone asked me why I didn't talk about osteoarthritis, and it's because there's nothing good to say about it, which is really, I think, unfortunate given that it's the most prevalent rheumatologic disease with so few therapies. But the management is very, very limited. We do a lot of, injections and anti-inflammatories and so on. I look forward to the day when we have some biologic modulator that will prevent all our knees from going bad. So that's why I didn't really talk about OA.
You got a question about is ankylosing spondylitis a form of RA or a separate disease?
I didn't talk about that at all. It's a different disease. It has different genetic susceptibility, which is HLA-B27 as opposed to HLA-DR4. It's more commonly, historically, seen in men than women, although it's underdiagnosed. And in some ways, it's kind of like a negative of RA, whereas RA lives out here in the periphery in your small joints. Spondylitis is an axial disease in your spine, your pelvis, your sacroiliac joints, your large joints. You can have peripheral arthritis with spondylitis, but the axial disease is the key. So it's very different. Although the same medications, the anti-TNF agents and methotrexate and azathioprine commonly will work in there as well. Good question.
There's been some great questions. Any particular considerations for the geriatric population? I'm not sure specific to, I'm not sure.
Well, in general, medications like anti-TNF agents are kind of nice because they don't have big adjustments for renal, if somebody's got an elevated creatinine, they don't cause hypertension, they're pretty easy to use in the geriatric population. I think steroids I've already referred to. Azathioprine and methotrexate are the same thing, the same rules. I think that when I see someone who is, my concept of elderly rises every year, but, people in their 70s and 80s who have inflammatory arthritis, I focus a lot on physical therapy and rehabilitation. I think that often the older population has several things already going on, and what you don't want to have happen is that this is the last thing that topples them over into a loss of independence. So I am pretty aggressive about sending them to a physical therapist for a home exercise program, but also it's kind of a cheerleading function. They go see the physical therapist who tells them what to do, sees them back, makes sure they're doing the exercises properly, and then encourages them to keep up with it. To the extent they're socially isolated, that can be important as well. For new onset inflammatory arthritis, reactive depression is an issue, and I think that's more common in the elderly. So I think you need to be aware of that. You need to be aware of, I think these are the things that you would do anyway, but making sure that they can take their medications easily. A number of the injectable medications have self-inject, so you don't have to have good hand control. And even if your RA is not bad, if you have a resting or other kind of tremor, then that's a very nice thing to promote their independence, but make sure they get their medicines. So I think that those are the kinds of things that I look at with the geriatric population. We don't sedate them, we don't use narcotics. I actually think that prednisone in the elderly population is often far safer than using NSAIDs, which can give them asymptomatic GI bleeds. So with RA, you need pretty small doses to cover inflammation. So I'm talking about 5 or 7.5 milligrams, not 40. And I think that's a lot safer than pushing a lot of anti-inflammatory drugs. And I personally don't think that Tylenol, acetaminophen, has any benefit in the inflammatory diseases, and also not very much in knee OA or hip OA personally. So I'm kind of generous with prednisone. And with Tylenol number 3 as needed. because I want them moving. I really want them not to stop.
Sorry. You mentioned that a number of unusual cancers were common with the treatment protocol of lupus. How long do we monitor, and can you name some of these?
The biggest one is the cervical cancer risk that's been identified. There have been black box warnings about lymphoma with most of the anti-TNF agents, and that's just a really hot topic of controversy in the rheumatology literature. They do reviews kind of every year at the annual meetings, and it's, yeah, it may be a little increased. No, it isn't. This past year, which was just in November, said there is no increase. It's clear that with RA, untreated RA, the inflammation alone was a predisposition to non-Hodgkin's lymphoma. And now as we're treating people, and we have this whole cohort of people who never were allowed to get to that persistent inflammatory state, I think we're going to see less of a risk for those cancers. But with lupus, I am most concerned about cervical cancer, and that's the one that right now I'm paying attention to.
And the related one about cancers listed as a side effect of Enbrel treatment. How big a problem is this?
So I personally think that it was mostly a finding that the early cohorts, because Enbrel was the very first anti-TNF, were people who had had really persistent disease and ongoing inflammation. In the same way that they had more heart disease, they had more risk for cancer. And I think that it's hard to separate then the persistence of the disease from the therapy. But that's what they found. Non-Hodgkin's lymphoma is a black box warning in all of the anti-TNFs. And we tell that to patients. The other one is an infection, which is PML, which is a very rare infection with a JC virus that I have fortunately never seen, and I think is only seen in more debilitated patients, and that was with rituximab use.
Any more questions, folks?
Thank you for your attention. I hope this was useful, and good night.
Thank you. This was great. Great job. It was great. Really great.
Kind of photo.
Yeah.